Hello friends, I am Dr. Skerdi Faria, founder of Keit Hospital. Today I am addressing body dysmorphia, a term often used to describe body dysmorphic disorder. This is a particularly important topic in medicine and aesthetic surgery because decisions must balance what is anatomically possible with what is psychologically appropriate. Treatments can change structure and size, but they cannot correct a distorted self-assessment when perception is impaired. The benefit of the intervention becomes unpredictable. Body dysmorphic disorder is not a simple insecurity, and it is not a normal dissatisfaction with appearance. It is a mental health condition where a person becomes excessively concerned about perceived flaws in their appearance. Often these are very minor imperfections, subtle or even invisible to others. But for the individual, they become an overwhelming thought. The core issue is not the physical feature itself. But what matters is how strong the pattern is, how persistent the concern is, and how much it interferes with daily life. The area where attention is focused can change. The nose, skin, jaw, hair, body shape. The specific feature may vary, but what remains the same is the sense of urgency and importance. Objective assessment is minimal. Many people have preferences or minor complexes. This in itself is not a disease. It becomes clinically significant when the attention to these details becomes excessive. It takes up a significant amount of time and negatively affects the individual's well-being. The manifestation is often a combination of mental, emotional, and behavioral elements. On the mental level, there are unwanted, repetitive thoughts that are difficult to control. Normal variations may be perceived as anomalies, asymmetry, deformity, and even minimal details can be seen as obvious flaws. On the emotional level, the suffering is often much greater than would be expected from the actual appearance, and this can manifest itself. Anxiety, shame, embarrassment, anger, and fear of judgment. In some cases, the distress becomes persistent, worsens in social situations, and can lead to withdrawal, lowered self-esteem, and a decline in quality of life. On the behavioral level, repeated actions are common, such as excessive checking in the mirror or complete avoidance of mirrors, detailed examination of photographs, constant comparisons with other people or with images on social media, and continuous seeking of reassurance from family and friends. Often this reassurance provides temporary relief, only for a short while, and does not stop the distress. A very important point is the impact on the individual's well-being. The person may avoid social gatherings, work, intimacy, or being photographed. They may spend a lot of time trying to hide perceived flaws with makeup, hair, clothing, angles, or lighting. When daily life starts to revolve around these behaviors, we are no longer dealing with a purely aesthetic issue, but with a problem that affects individual well-being. Another important feature is the instability of satisfaction. In body dysmorphic disorder, intervening in a single area does not guarantee relief. The distress may continue even when there is a noticeable improvement, or it may shift to another part of the body. This is why the topic is so important in medicine and aesthetic surgery. Even a correctly performed procedure may not be experienced as sufficient. For this reason, in medicine and aesthetic surgery, dissatisfaction alone is not enough to justify a procedure. The doctor's responsibility is not to automatically fulfill a request, but to assess whether an intervention is appropriate. It must be safe and likely to bring a lasting benefit. When body dysmorphic disorder is present, the results can be unstable because satisfaction depends much more on perception than on actual change. In these cases, the patient may seek repeated corrections, pursuing a relief that surgery cannot guarantee. Therefore, counseling should go beyond the technical aspect. A thorough assessment includes the reason for the request, expectations, and the possible impact on the patient's life. Some signs require extra caution. A strong focus on minor details, the belief that the procedure will solve broader emotional problems, and a history of multiple interventions or persistent dissatisfaction. These do not in themselves define the diagnosis, and it is not the doctor's role to hastily assign labels. However, they indicate a higher risk and require a more careful decision. The ethical consequences are clear. Proceeding with intervention when the possibility of psychological benefit is low and may cause harm, such as increased fixation, repeated procedures, disappointment, and worsening of mental well-being, should be avoided. In these circumstances, the intervention itself can become part of the problem. A conscientious practice requires the ability to recognize when care and restraint are the safest choices. Postponing or refusing a treatment may be appropriate, and suggesting a psychological evaluation may be necessary. This is not a judgment, it is protection. Psychological sensitivity deserves as much attention as physical contraindications because it directly affects perceived outcomes. It is important to clarify this, as well as professional boundaries. The goal is to recognize patterns that indicate sensitivity, to communicate clearly, to set realistic boundaries, and to refer to a specialist when necessary. Body dysmorphic disorder responds to evidence-based psychological treatments. Structured therapies can reduce excessive preoccupation, limit compulsive behaviors, and improve daily well-being. In selected cases, support with medication under specialist supervision may also be needed. The goal is to improve the condition and daily life. Not perfection, stigma remains an obstacle. Many people minimize their distress out of fear of being judged and come in with a simple aesthetic request while actually experiencing significant suffering. A professional environment should allow for the discussion of this topic. With respect, psychological health is part of care. In conclusion, body dysmorphic disorder is a mental health condition characterized by persistent concern over perceived flaws in appearance. Accompanied by distress, repetitive behaviors, and a significant impact on quality of life in aesthetic medicine and surgery, it has direct importance because it affects outcomes and risk profiles. Physical interventions can change the form, but they cannot correct a distorted interpretation. Responsible care requires accurate assessment, appropriate timing, and the willingness not to intervene when it is not advisable. Thank you for listening.